is a joy to be here. I traveled to a lot of states to help them set up perinatal quality collaboratives and maternal mortality reviews, and it's always a two-way street. I learn and bring back to California experiences in New York or Indiana, where I was last month, here as well, and that's really the hallmark of quality collaboratives is unbridled sharing with each other. What I'm going to do today is to talk about some of the lessons we've learned nationally as well as in California in data-driven quality improvement for maternal mortality reduction. And as we'll get into severe maternal morbidity, which is, if you will, 100 times more common than mortality. I actually have the honor of also chairing for the last 12 years our maternal mortality review committee. And that's really a key here, is to link the maternal mortality review committee to action. Let's see. What we're going to be talking about today is how you take what you learn in maternal mortality reviews, put that into action, and actually change numbers at scale, at the level of a state. Actually, as I usually start off telling you a little bit about California, California is a large country in the western part of the United States. 40 million people, it's the 5th largest economy in the world. It has 500,000 births a year, which is 1/8 of all the births in the United States. 500,000. And that gives us kind of a responsibility, too, because that's 500,000 births in one legal jurisdiction, which means that we have access to all the medical records, all the autopsy reports, all the hospital discharge diagnosis files, as well as the death certificates and birth certificates for 500,000 even at once. And that's the size, almost the size of France and Great Britain. We model what we do a lot about what's happened with the confidential inquiries in the United Kingdom, which is also very much a project that links death reviews to improvements in care. I would emphasize what Don said at the beginning, that the actual numbers are tricky and have to be taken with a plus minus. The trends are real, but the deeper you look, the more deaths you find. And if you go to social media, if you go to the internet, you'll find deaths that aren't really reported elsewhere. Because of the linkage of trying to decide whether this woman was pregnant or not, or recently pregnant, or in the last year was pregnant, is a tricky assessment to make. And we'll talk about that as we go forward a bit here. Before we start, we have to point out that, and this is a CDC slide, that maternal mortality reduction has been one of the biggest public health successes in the last century. This is where the United States was in 1900, up to where this is the same level as what we see now in Southern Africa or Afghanistan. You know, huge numbers of maternal deaths. This big blip that you see right here is 1918. You see the influenza epidemic that preferentially affected pregnant women. But then in the 30s and 40s, there was a huge decline in maternal mortality. You know, this is the time of the Great Depression, World War II. This is the time of wealth in the United States. Yet maternal mortality was able to be reduced by this huge proportion. And Don talked about some of the reasons for that in terms of focus on asepsis, focus on maternal mortality reviews, which all started in this time period, in response to the high levels of maternal mortality, and lessons that were learned and put into action. However, what we've seen in the United States is a rise, unlike other developed countries, other high-resource countries around the world, where all of them have declined. In the red, you can see going up to 26, plus or minus again. There's different studies will have somewhat different numbers, but all of them agree that it's much higher than other developed countries. The CDC, for example, calculates it a little differently when they look at their pregnancy-related mortality, which is different from maternal mortality, and I'll discuss that in a moment. But they also have seen a decline, an increase, again going up in a parallel way to maternal mortality. Not only that, but severe maternal morbidity has gone up by 100%. We described that. The cesarean births in the same time period have increased 50%. All of these are pretty big numbers when you get to looking at a population level. So we've had a lot of interest in severe maternal morbidity. This is occurring at 1 to 2% of births. So unlike maternal mortality, which is about 2 per 100,000, now this is 2 per 100. Okay? And this is one of the measures that we use for quality improvement, because this is now something you can measure at a hospital level, you can measure easily annually with administrative data and follow statewide. But this has gone up twofold, you doubled 100% increase in this time period from 1999 to 2011. And in the years since then, it has continued to rise. So the U.S. is now almost, instead of 1.6%, it's pushing 1.9 to 2%. So let's talk about definitions for a moment. Maternal mortality is the WHO definition presented here, which is a death during pregnancy or within 42 days after delivery, causally related or aggravated by the pregnancy. This is the international definition used to compare nations in the international literature. It is based solely on death certificates. That's a problem. They have to have an ICD-10 diagnosis in the obstetric region. I mean, both those. And this is calculated by the National Center of Health Statistics. That gives you that 26 number that you saw in the previous slide. The CDC has used a somewhat different definitions for quality improvement and analysis purposes, not so much for national measures or comparison purposes. And that's where we get pregnancy-associated, pregnancy-related deaths. Pregnancy-related deaths are similarly defined, but based on different case ascertainment, i.e., you're looking here at not on ICD-9 codes, but in addition, looking at linkage between birth and death certificates to try and define, but you also realize that not every pregnancy ends with a birth certificate. Right? There are topic pregnancies, and miscarriages, and stillbirths, and you have to be able to capture those as well. And it is ideally what is used by state maternal mortality, if you like you're doing here in Virginia. Pregnancy-associated mortality is any death within a year, of any cause. So that includes a whole variety of causes that are not related to pregnancy, motor vehicle accidents being one of the most common ones. But it catches, it's easier to catch the bigger denominator of which to review cases for, and it has importance in its own right, and we're going to talk about that. But you should recall that naturally only about 1/3 of all the deaths that are pregnancy-associated would fall into the category of pregnancy-related, i.e. causally related to the pregnancy. So the definitions between maternal mortality and pregnancy-related mortality are pretty similar, except remembering they have different denominator bases. That they're related to the pregnancy in 42 days. Well, actually, pregnancy-related mortality can go a lot further, as we see cardiovascular disease in particular often ends up with a mortality that's beyond 42 days. So this is some of the Virginia data that's in the recently released report looking at all pregnancy-associated deaths. You see it's about half of that would be qualified as accidents, homicides, suicides, or undetermined, and half that is natural. And what natural means in birth and death certificate worlds is by typically a medical cause. And we'll talk about that in a moment here. When you look at the biggest cause there, accident, that also includes overdoses. And actually in this state, it's about half of them are overdoses. 13% of all the deaths within the year after delivery, pregnant or within the year, are due to overdoses. natural, about 20% are medical causes that are probably not related to the pregnancy. And that would go along with the national data suggesting 1/3 of all the pregnancy-associated deaths would be pregnancy-related. So let's look at pregnancy-associated versus pregnancy-related, the implications there. It's about timing, partially. It is very difficult, oftentimes, to tie something that's 6, 8, 10 months after delivery to the delivery itself. You want to look in particular, for example, are the deaths that you see in that year after delivery different from the deaths that you see in other reproductive age women? There are a lot of typical causes of death that you see in reproductive age women. They're going to happen, of course, in the same time period, only in that 1 year afterwards. For example, are suicides more or less common during pregnancy and postpartum than in non-pregnant women? We finished a review of over 100 suicides in California just recently, about to be released. And actually, pregnancy is protected. There are very few suicides during pregnancy and in that first 6 weeks, and then gradually increase up to a non-pregnancy rate as the year. But the number of suicides in that year are influenced by the number of suicides in young women. And I'll show you data in a moment to suggest that overdose deaths follow the same pattern. So here are the natural causes of death in Virginia by count. You see, we generally don't look at AIDS and cancer deaths as pregnancy related. That's why we're bringing there. The ones that are more questionable, that may or may not be, include disorders of CNS, which is typically intracranial hemorrhages from varied aneurysms and malformations, chronic disease, and other categories of death may or may not be related. So the classical pregnancy-related ones are in pink. And what you're seeing here, in terms of the percentages of that, are going to be pretty similar to what's seen nationally in other states, which is hemorrhage, pulmonary embolism, hypertensive disease, and infection are 10 to 15%. Over and over again, you see that in our state and other states. The cardiac disease is the biggest driver, and that's nationally now. It was mentioned, and that's what we see in California. What we see, though, is actually 2/3 of the deaths in our state are cardiomyopathy, and 1/3 are underlying cardiac disease. And that may be something to look at a little bit. We have autopsy reports on all of these, and but that's a real opportunity. This is what I think is one of the key areas for referral to tertiary centers. Women with cardiac disease is a big target. So looking at the more classical or the overall pregnancy-associated deaths in Virginia here by race. And what's shown here is there's not that much difference in the percentage of deaths by each race for most of the causes, except for overdose deaths are much more common in white women. Suicides is considerably more common in white and other Asians in our state. And homicides are much more common in black women. So black women have fewer suicides, fewer overdoses, and more homicides in proportion. But you look at the other types of causes of death. Overall, black women are higher, but the percentages of causes were similar. Again, going along with the North Carolina data that Tom was talking about earlier. And then this is the more classical pregnancy-related deaths in Virginia. Again, black-white differences are relatively or similar in terms of the proportion of deaths among black women, and similar to the proportion of deaths in white, even though blacks are overall higher by threefold. Now, when you look at maternal mortality overall nationally, this is multiple studies put together here. The first column of mortality, just to give you a rule of thumb, mortality is 1 to 2 per 10,000, or about 20 per 100,000. So it's not a big number, but it does serve as both the canary, as Don said, and the metaphor I use is the tip of the iceberg, because it really is the tip reflecting the morbidities we're going to cover here in a moment. If you look at near misses, not a great term, but typically defined as ICU admissions, that's 1 to 2 per 1,000. You know, big centers have more, little centers have fewer, but 1 to 2 per 1,000 roughly. Now the proportion of deaths changes significantly from the 10 to 15% of the causes of mortality for venous thromboembolism, infection, and hemorrhage and preeclampsia. So hemorrhage and preeclampsia are now much more common. If you look at severe maternal morbidity, the way the CDC presents it, defines it, with a series of ICD codes, so it can be calculated population rate annually or quarterly even. You see the hemorrhage and preeclampsia dominate. They're the biggest causes of morbidity in the birth time period. Not the whole long year, but in the birth time period, that birth, pregnancy, and up to 42 days. So this is going to feed into where we're going to put our emphasis. So now I'm going to go through some of the California data and show you what we've been working on in California. We just, to start off with, have seen a similar 3 to 4 times higher rate of maternal mortality among African American women in California. This is 9 versus 39. We saw similar rates by cause, with the exception of cardiovascular deaths. Here was 7-fold higher. And that's a particular interest to us and it's largely underlying cardiomyopathy, which we'll get into in a moment. But this is pretty striking. It's a little different from the national data, and I think underscores one of the importance of having each state have its own maternal mortality review committee. Each state's different. You're not going to want to go to your docs and nurses and patients in Virginia and say, well, let's just take California data. You have to see what happens in your own state. And each state's going to be different. New York, as I'll say in a minute, is very different from what we are in California, New York City. But one of the underlying lessons that we've seen again and again is, what can you do cardiovascular disease in African American women? And one of the take-home lessons that we've had is this should be an alert for everyone. That if you're African American and you're overweight, particularly if you're older, and if you have hypertension, that's really a combination of risk factors that put you at very high risk for cardiovascular disease, implying that any symptoms really need to be evaluated. Not just say, oh, you're going to be better, or it's just because you're pregnant or you're short of breath. Then you have to be really sensitive to new onset asthma, wheezing. Asthma is very rarely new onset in adults. And particularly in this setting, you have to think of what is also called cardiac asthma, i.e. that it's a sign of heart failure, that you're wheezing, not an airway issue. So it's of interest that we have a big focus on not just maternal mortality, but cause-specific issues, i.e. that women who die from venous thromboembolism are different from women who die from preeclampsia or from hemorrhage. They have different time courses, as seen here. As expected, if women who die of AFEs and even hemorrhage die very rapidly in the first days or week after delivery. whiskers plot where the line in the middle of the box is the 50th centile, and the box itself encompasses 25 to 75% of patients. And the tail goes out to about 95%, roughly. And you can see the venous rumble goes out for 3 or 4 weeks. Preeclampsia, maybe a week or two, with 75 percentile, 95th percentile by about 2.5 weeks. Cardiovascular disease is a whole different scale. Whole different scale. Now this is going way out. 50% is early, because there's a huge peak early, it's sort of shown in this kind of a distribution here. But there's a long, long tail that goes out to actually multiple months, reflecting cardiomyopathy. So this, I'd like to talk, I'm going to be referencing the journalism that's come out the last 2 years, both in terms of USA Today and the NPR and ProPublica articles, which I think have been very, very influential, much more than anything I've ever written. They have galvanized even Congress to take some action on this. The USA Today has three big articles in this series. This is the middle one. That really has focused on pushing states to do maternal mortality reviews and to set up prevention steps. And this is really a key, but also it's really important to get into the issue of we can look at the underlying causes, but underlying risk factors, but that doesn't mean those are the causes of death. Important distinction. For example, when we look at obesity, which is clearly a risk factor, it's very different depending on the cause of death. For example, women, this is a slide showing the gradations of obesity. Blue here is normal and underweight. Overweight, BMIs of 25 to 30 are in red, and then obesity, different grades of obesity, 1, 2, and 3 are the green, purple, and blue at the top. And this is a control group of the normal, of all pregnant women in California on the far right. And there are only 2 causes of death in which obesity was in a higher proportion. So most of the women who died from preeclampsia, obstetric hemorrhage, AFE, were not obese. But the 2 causes of death which did have a lot of obesity were not surprising. They were women with venous thromboembolism, who died of venous thromboembolism, or women who died of cardiovascular disease, which are obesity is a clear risk factor for both of those, whether you're pregnant or not. But that also helps you focus in on action steps in terms of you're going to treat obese women differently in terms of your assessment of their risk for thromboembolism after C-section, for example, than women who are lean. And likewise, in terms of your assessment for cardiovascular disease, you have to take that into account. So we like everyone, has been interested in preventability. And actually, preventability is not an easy thing to define or measure, because obviously it's retrospective. You're not there. You don't have all the facts, even if you have the entire medical record. There's a lot that happens that's not in the medical record. But there's, the definition of preventability is a bit tricky. We decided to do chance to alter outcome, and we graded that as none, some, good, or strong, because it was actually hard to get a group of physicians and nurses and social workers and everyone in our medical review committee to be able to say yes, no, preventable, not. So we wanted to give it some leeway. At the end of the day, we did combine good and strong, and this was shown here. But other states have taken other approaches. North Carolina, in their review, just said preventable or not preventable. In the United Kingdom, the confidential inquiries did substandard care that had a major contribution to the death. But it's interesting when you look again by cause of death. Here we have hemorrhage, preeclampsia, sepsis, VTE, cardiomyopathy, AFib. The three definitions in the three different review committees came up with pretty similar responses here, pretty similar results. The hemorrhage and preeclampsia had the highest rates of preventability. And all the way down at the bottom, the AFEs were challenging, shall we say. Actually, when we looked at some, we thought there was some in a fair number of cases. There was only some. Cardiomyopathy was more challenging, largely because of the time course and the distance from care for many of the women who died from cardiomyopathy. And there were some differences in opinion about VTE prevention. So, when we looked in particular at hemorrhage and preeclampsia, as to, in our reviews of the deaths of those, again, we had a pretty large number in such a big state, we focused in on those same three categories of provider, system, and patient level, and found a whole lot more options, opportunities to improve in the provider. And it was largely in things like missed triggers, missed risk factors, abnormal vital signs that were missed, things like severe pain that was ignored, altered vital status that was ignored, and lack of planning for patients at high risk, or underutilization of appropriate treatments. It was interesting. When we died from hemorrhage at a DNC to try to remove retain products of conception, at a second DNC, at a third DNC, at a fourth DNC, and didn't move on along a plan of management. And that was a recurring theme, is that there was not a plan of management for hemorrhage. People tried the same thing over and over again. Or in hypertension, we'll get to in a moment, that they really found many reasons not to treat the hypertension rather than to expeditiously get that. In some of our hospitals, there were difficulties getting physicians to the bedside. They were at home, they were dismissive. The bleeding's going to stop, or let's turn it around the side and measure the blood pressure again, those sorts of responses. And then interesting, it's not all labor and delivery. We had deaths, particularly from preeclampsia, in the ED, presented to the ED, or in care in the PACU. And that really broadens the quality improvement locations that you have to deliver to really get the impact that you're doing. So a similar approach was taken by the University of Illinois, looking at a big perinatal network in that state. And they had pretty similar findings, a little less granular in their descriptions. But these were present in 90% of cases of deaths from hemorrhage and preeclampsia. 90%. So, we decided that these were the two causes of death that we really wanted to focus on first. They were the most preventable causes of maternal mortality, or the most common causes of severe maternal morbidity. 75–80% of all severe maternal morbidity is these two causes. And they had high rates of quality improvement opportunities that are easily summarized as denial and delay. And that's been our mantra for the last decade. We want to focus on denial and delay. So going back to the ProPublica NPR series, they really have impact because you have to match data with stories. And in fact, a lot of what we do in maternal mortality reviews is get that data, but it's actually useful to turn them into de-identified stories. Because when you approach people to change their behavior, you have to work not only with your head, with understanding data, but you have to change, you really have to change in your heart. And that's what stories do. This is a story. They started off first with this story, the whole series, of a NICU nurse and physician who died in their own hospital. The last person you expect to die, a child. And it was a preeclampsia that was not recognized on day 2 or 3 postpartum. And a lot of the deaths in preeclampsia now are postpartum. They went on and recognized that an excess number of deaths are obviously in Black women, but they wanted to start off with this woman who you really had the least suspicion, the last person you'd expect. In the USA Today series, and I was thinking of showing some of these short videos here, but we didn't really have time. I really encourage you to go to this site, and just USA Today Maternal Mortality, Google it, they'll all come up. Danielle Bell story, these are women who had near misses, so they could tell their stories. They all almost died. And very informative. There are 28 of them. I watched, they were under 2 minutes each. I watched them all one night and I cried. They were that powerful. In fact, in our maternal mortality review committees, we have to pay attention to the mental health of all our physicians and nurses. Because I'll tell you, the hardest ones were the suicides. That was really difficult for us. But our goal in the maternal mortality reviews was to really have it be to honor the women who died and the teams who cared for them, and to have it turn into something valuable to make it not happen again. And that changes your feeling as you're doing the reviews rather than just looking